So I'm going to talk today about some of the practical aspects in anesthesia for thoracic surgery. See, when I started out, things were different. You notice, when I started out, things were different in anesthesia. And the reason for that is that at one time we used ether, and it was given by mask. Now it works pretty well if you're doing abdominal surgery or if you're doing peripheral surgery on the legs. But if you're doing thoracic surgery, it doesn't work at all. Normally, if you have an intact chest, every time you inspire, the lungs inflate, and on expirations, the lungs deflate. Well, if you make a hole in the chest, a thoracotomy incision, what happens is the lung collapses. You have paradoxical breathing. The lungs collapses on inspiration and expands during expiration. And actually it causes a very rocky breathing pattern. The Germans have a name for it. They called it Pendelluft. And the patients became very dyspneic, cyanotic. They had cardiovascular collapse, and unless you closed the hole very quickly, the patient died. And so in the era of ether anesthesia, there was no such thing as thoracic surgery. And to make matters worse, because you were anesthetizing the patient by mask, you couldn't protect the airway. And the greatest cause etiology for surgery on the chest 100 years ago was infection. And so rather than the normal lateral decubitus position, the patient had to be operated in a head down position so you didn't contaminate the good lung with all the pus. Well, things started changing in 1928. Gale and Waters in 1928 put an inflatable cuff on a tube, and we had our first tracheal tube. Very shortly afterwards, 3 years later, they applied this to one lung ventilation. They stuck that tube down the airway. So this lung, the unhealthy lung, the operative lung, was not involved in the positive pressure ventilation. And so they had a quiet surgical field. The patient wasn't breathing on their own. They could protect the airway, and there was some degree of cardiovascular stability. Therefore, believe it or not, the first pneumonectomy ever performed was just 80 years ago, 1931. So at the start of the endotracheal intubation. The first pneumonectomy for a malignancy was performed just 2 years later. The first esophagectomy, 1933. There was no thoracic surgery before the anesthesiologist figured out a way of keeping the patient alive with an open chest. So if you read the old textbooks of surgery, and I'm sure no longer mentioned, they talked about absolute indications for lung ventilation. The original indication was to protect the healthy lung from empyema, and it's still you would consider an absolute indication. There's certain operations that can't be done unless you selectively collapse the lung, and you can't do a thoracoscopy unless the lung is quiet and not breathing. The textbooks also talk about relative indications depending on the type of surgery. There are high indications where surgical exposure is more important than those where it's less. I think that one lung ventilation is now safe, easily performed, and is really indicated for all intrathoracic procedures. So you know here at Stanford, not only on the lung and mediastinum and the esophagus, but for aortic aneurysms, for major spinal cord corrections, for sympathectomies, we do one form of one lung ventilation. There's no longer absolute or relative indications. I think every thoracic surgeon trained in the last 20 years expects the anesthesiologist to provide collapsed, selectively ventilated lung for them to perform their surgery. So there are three ways to accomplish that. You can use a double-lumen tube, you can use a bronchial blocker, or you can put an endotracheal tube into the bronchus, where it becomes an endobronchial tube. We'll start with endobronchial intubation. That's actually what they did back in 1931. Not only did they stick the tube in the bronchus, but it also was a bronchial blocker. It obstructed flow here. As I'll be showing you through the course of this thing, there have been lots and lots of different tubes that have been used in the history of anesthesia. We don't use any of them now, but there are a whole variety of endobronchial tubes that were designed. This one I find interesting because it's the forerunner of the double-lumen tube. It actually has two cuffs but only one lumen. So you ventilate the patient, you inflate the tracheal cuff, and you can ventilate both sides, and when you inflate the bronchial cuff, you only ventilate one side. The problem with the conventional endotracheal tube, has anybody in this audience ever seen a real endobronchial tube, one designed for thoracic surgery? They don't exist any longer. There's one company in England that makes them, but we don't have them here. The problem, here's an endobronchial tube. Look at the distance between the cuff and the tip of the tube compared to a normal endotracheal tube. If you take an endotracheal tube and you put it down the airway till the cuff is below the right lung, you're going to obstruct ventilation to the left upper lobe. And if under fiberoptic control you pull that tube back so that the left upper lobe is not obstructed, the cuff will no longer be in the bronchus and you'll be ventilating two lungs. So endobronchial intubation is not really an option. It's only an option really if you have a massive hemorrhage, especially only on the right side, and you want to ventilate the patient and isolate the right side. So you could put an endotracheal tube down and position it on the left side. If you have a bleed on the left side, you're assured of obstructing the right upper lobe bronchus because of the anatomy. So it's not really a practical approach to one-lung ventilation. The oldest approach is bronchial blockade, and anything that can obstruct the airway will cause lung tissue distal to that obstruction to collapse. So a lot of different things have been used. The Swedes used initially a gauze tampon to obstruct the airway. Here are all the different bronchial blockers that were designed over the years, which you'll never see. Back in '36, this bronchial blocker had to be put in with the anesthesiologist using a rigid bronchoscope. Has anybody in the audience ever done rigid bronchoscopy? It's an art that we no longer have in anesthesia, but that's how they placed bronchial blockers 70 years ago. The first modern bronchial blocker was the Univent tube. Now we do have these at Stanford and they're very rarely used. Has anybody used a Univent tube? It's basically a regular endotracheal tube, but it has a small little channel. And through that channel there's another catheter that can be advanced into the bronchus, and at the tip of that catheter there's an expandable balloon. So you intubate the patient as you would with any endotracheal tube, and then under fiber optic vision you advance this tube into the right or left bronchus, expand the balloon, and you have bronchial blockade. The real benefit, I'll go back, is the way they saw this initially is this: if you have a case where you know you're going to ventilate them postoperatively, particularly in esophagectomy, you're going to get lots of fluids and they're going to be edematous. If you put a double-lumen tube in, it might be too dangerous to pull out the double-lumen tube and exchange it for a bronchial blocker. So the original indication for the Univent, I'll get this right yet, for the Univent tube is at the end of the case, you just deflate this cuff, you pull it back in, and you have an endotracheal tube already in place, so you don't have to take the risk of reintubating the patient. It's not become very popular, and again, has anyone in the audience ever used a Univent tube? We have them here, and you could try them out.
Dr. Brosky, can you fit a scope and the extra catheter both through the same tube?
Yeah, no, the extra catheter is already built in. That's one of the downsides, and these tubes are very large.
Okay.
That's one of the real problems. And they're also made of silicone, so it's not the thin plastic. It's even more difficult. Bronchial blockade really means any balloon tip catheter through an endotracheal tube. And we have non-specific ones and the modern bronchial blockers. So anything that has an inflatable cuff balloon at the end has been used, including a PA catheter, Fogarty catheters, those were the popular ones. If you can inflate the balloon and you can position it, you can obstruct flow to that lung. The real breakthrough in bronchial blockade came with the introduction of fiber optic bronchoscopy, and that's only again in the late 60s, 70s. A blocker has to be positioned with a fiber optic bronchoscope. You have to make sure it's where you want it to be. If it's not deep enough, you're going to obstruct ventilation to both lungs. This is another major advance, and for those of you who do use bronchial blockers downstairs, this is the ARNT multi-port adapter. In order to place blockers in the past, you basically had to stop ventilation and advance the blocker under direct vision. This allows you to continue to ventilate the patient through this port while putting the bronchoscope through this port and advancing the blocker through this port. And this is what it looks like. So nowadays we can place bronchial blockers without making the patient apneic and stopping ventilation. They continue to be ventilated. The blocker is advanced, and under direct vision the bronchoscope allows it to be placed into either lung. So there are two popular bronchial blockers we have. The first is the ARNT. The ARNT has this wire tip at the end, and so before you connect the connector to the endotracheal tube, you feed the bronchoscope through this little loop. Then you connect and ventilate the patient, and you advance the bronchoscope down into the lung you want to obstruct. And then you slide, as you're doing that, you slide the blocker along the bronchoscope. So the bronchoscope is used to enter the lung you want to collapse, the operative lung. You slide this over it. So you don't initially see positioning until you then pull the bronchoscope back. The other one is the cone blocker, which you do under direct vision, and you basically have this little wheel that allows you to twist it. So you're watching it as it enters, goes down the trachea, the bronchoscope's behind it, and you can twist it and it can go into the right lung or the left lung. So you can use either of these for either. The people who made the Univent tube, they saw they weren't selling their Univent tubes, but they were selling the blockers, so you can actually get the Uniblocker, which is the blocker from the Univent tube without the Univent tube. And then finally, there's one that I've just seen in Europe last year, and it's not available, but they promised me that we'll be the first ones in the United States to get to use it. And it's called the Easy Blocker, which is basically a blocker that, as it enters the carina, it bifurcates, and one goes in the right, one goes in the left. They both have balloons. So in theory, it wouldn't require fiberoptic bronchoscope. So you do have an emergency. You got to isolate the lungs. You insert it. It goes past the endotracheal tube. As it goes past, it expands out, and the two lumens, one goes into the right, one goes into the left, and then you just blow up the balloon on the side you want to obstruct. And that works great in models, but they haven't introduced it in the United States. So I don't know how great it's going to be, but we're going to be the first ones here to get it. The use of a double-lumen tube or bronchial blocker is personal selection. I mean, some people feel more comfortable with a blocker, some people feel more comfortable with a double-lumen tube. However, if you blind the surgeons and you ask them which they would prefer, it takes a shorter period of time to position a double-lumen tube. You're more often accurate with a double-lumen tube, and the lung collapses a lot sooner and better. So if you blind people, although there are some people who do, anesthesiologists who do recommend bronchial blockers, they're more comfortable with it. The double-lumen tube is really the gold standard. When do you use a bronchial blockade? In my opinion, my practice, when you can't place a double-lumen tube. When you have a really difficult intubation, such as somebody in a cervical collar who can't open her mouth to get a double-lumen tube in, you can use a bronchial blocker through an endotracheal tube placed nasally, orally, or even through a tracheostomy. So if you have a situation where you can't get a double-lumen tube in, or you're concerned about changing an endotracheal tube to a double-lumen tube, bronchial blockers used. Here's a guy with a very tiny tracheal stoma. In fact, it was so small we couldn't get an endotracheal tube in that would accommodate the bronchoscope. So you can see we had it in the old days, had a Fogarty catheter, put the bronchoscope in, position the bronchial blocker, and then put the endotracheal tube in. You can see the blocker here. So this patient clearly wouldn't accept a double-lumen tube, but I got scores of pictures of patients with tracheostomies with double-lumen tubes. If the tracheostomy is big enough, you can even put a double-lumen tube in. But the big indication for bronchial blockers is pediatrics. As you can see, there's this no double-lumen tube that's commercially available that's going to fit a child that's less than 8 to 10 years old. So the real use of bronchial blockers is in little ones. You can see the blocker going in here. You can see the blocker in the lung. So in my opinion, the double-lumen tube is the gold standard. A double-lumen tube is exactly what the name implies. It's two lumens that are molded together. There's a short lumen that ends in the trachea. There's a long lumen that ends in a bronchus. There are two cuffs. If you inflate the tracheal cuff, you can ventilate both sides. If you inflate the tracheal and bronchial cuffs, you can ventilate both sides, or you can clamp off ventilation and isolate one of the lungs. What are the advantages of a double-lumen tube? They're easy to position. They're much less likely to be displaced than a bronchial blocker. When you're turning a patient during surgery or to position and that bronchial blocker pops out, then you got serious problems because it's going to obstruct ventilation to both sides. The double-lumen tube protects each lung from contamination. I think one of the most important reasons to use a double-lumen tube is it allows you to collapse, re-expand, collapse the lung anytime during surgery. For those who've done thoracic surgery, you know the surgeon often asks you to re-expand the lung prior to him clamping the bronchus to see if he's clamped good lung. The double-lumen tube allows you to do that. With the bronchial blocker, once you release the blocker, that's it. The other thing is you can do pulmonary toilet on the operative lung. With the blocker, you can't. So with a double-lumen tube, you can suck out all the pus and mucus and blood and tumor that's in the operative lung before you re-expand it. It allows you to put a bronchoscope in so you can inspect the operative lung at the end of the case, see if there's any injuries. You can put CPAP, which we'll get into in a little while, during surgery through a double-lumen tube. You can't do that through a bronchial blocker. And finally, if you're in the ICU and you have a patient with a double-lumen tube and you've had injury to one lung, you can have two different ventilators and do independent split lung ventilation. So there are a number of advantages to a double-lumen tube. The first double-lumen tube was invented by Carlins. This Carlins tube was first used in 1950. It has the famous coronal hook. Remember, this is before fiberoptic bronchoscopy. They had to know how far to put it in. They'd advance it until the hook hooked on the corona. And again, there were lots of different designs for double-lumen tubes over the years. In 1962, Robert Shaw introduced this tube. This is the tube that all modern double-lumen tubes are modeled after. It has no coronal hook. It has a more gentle anatomic shape to it than the Carlins tube, and it has much wider lumens. Remember, this is made out of thick red rubber. I have some in my office. I should have brought it for show and tell today. But it's amazing how thick that rubber was and how small the lumens are. All the modern double-lumen tubes, and there are a couple more now, are all basically the same as the Robert Shaw tube. This is a new one from the people who brought us the Univent tube. It's called the Silobronch tube. It's a little different. It has reinforced distal end, but you also notice it has a very tiny little balloon and tip. Again, it's to increase the safety of positioning in it. The wider that bronchial balloon, the more chance you have of obstructing the upper lobe bronchus. So, for those of you who've worked with me, we're just going to go over the steps to place double-lumen tube. First one is to select a left-sided double-lumen tube when possible. The reason for that is human anatomy is asymmetric. The left mainstem bronchus is very long. The right mainstem bronchus is very short. You have a much greater chance of successfully placing a double-lumen tube without obstructing the upper lobe bronchus if you use a left-sided tube. If you do use a right-sided tube, and there are indications for right-sided tubes, they're all different. They're different from the left-sided tubes. They all have some slot, some opening for the right upper lobe. And the idea is to put the tube in so this slot is opposite the right upper lobe. So you see in this Mallinckrodt tube, the cuff is not even like you see on a left-sided tube, but it's at an angle here. Of course, it's very, very easy to obstruct on the right side. In fact, a certain percentage of the population, and you can't see this with lights, have a right upper lobe bronchus that originates at the corona. Actually, less than 1% of patients have a tracheal right upper lobe bronchus. So for these patients, here's left, right, and here's the right upper lobe right at the corona. This patient would be impossible to safely place a right-sided tube if you plan to ventilate on the right side. Obviously, if you plan to ventilate on the left, if you plan to ventilate the right side, a right-sided double-lumen tube would obstruct the right upper lobe bronchus. So what are there are indications. There are times when you can't use a left-sided tube. The main one is if the left main bronchus is obstructed or if the surgeon's operating on it. So here, for big aortic aneurysms, if you try to put a left-sided tube down a compressed left bronchus with an aneurysm, there are cases of ruptured aneurysm. Obviously, if a tumor is obstructing intrinsically or extrinsically, if the surgeons are working on the left main bronchus, then you have to use a right-sided tube. So the next step is to select a large tube for your patient. Now that sounds counterintuitive. Large tubes are dangerous, small tubes are safe, right? Wrong. First of all, large tubes can't be advanced as deeply. So there are fewer positioning problems if you're using a large tube, an appropriate size tube in the bronchus. And there's actually less trauma because the smaller tube in the bronchus, the more air you have to put in that cup to seal it. And presumably you can overinflate the cup. But the more important reason for using a large tube is there's less resistance to airflow. You're ventilating the patient with a tidal volume, then you go to ventilate half the lung volume. If the patient has severe emphysema, like a lot of patients having thoracotomies, they develop what's called auto-PEEP. You can push ventilation in, but it takes a long time for expiration. And the smaller the lumen, the greater the resistance for the flow out, the greater what's called stacking, or the production of auto-PEEP. And of course, it's easier to use a bronchoscope or a suction catheter through a larger lumen. So how do you choose the correct size tube? Well, you can choose it by gender, right? Men have larger airways, women have smaller ones, and height. Small women have small airways, tall women have. That's wrong, but that's recommended, and that's how some people still do it. Select it based on the height and gender of the patient. The real thing that you want is you want to get a large tube in the bronchus. So if you know the size of the bronchus, you can select a tube. If you know the dimensions of the tube, it will fit that individual's bronchus. And so all the tubes are different, and here at Stanford we use the Mallinckrodt tube. And what you can do is you can go to a CT scan and you can directly measure the left bronchial width. There's a problem with that. The cut is horizontal. This is an angle. You need calipers because it's a much reduced size. You can measure the bronchus on a chest X-ray. Right? You can directly measure it. The problem with that is most chest X-rays don't look like that. They look like this. And next time you go to the OR, if you pull up a chest X-ray and try to identify the left bronchus, you won't in at least 50% of the cases. But you'll always see the tracheal air column is present on every chest X-ray. So what we found years ago by going through the anatomy literature is that the bronchi are directly proportional to the trachea. Every single person in this audience has a different size airway. But if you can measure the trachea, you can predict the size of the right and left main bronchus. And the left main stem bronchus are about approximately 2/3 the size of the trachea. So what we started doing years ago, and we have now probably 15 years experience, is measuring the width of the trachea at the clavicles and selecting a double-lumen tube. And here's a paper about, one of the papers we've written here showing this is, it's a biological thing. There's a bell curve, but there's this relationship. And so since we use a Mallinckrodt tube and we know the size of Mallinckrodt tubes, if the patient has an 18 millimeter trachea, we use a 41 left tube, 16 to 39, and so on down the line. Now, we did a study to see what happens if we use that gender formula. The asterisks show you the size tube that would have been chosen if you went by small woman, small trachea, large woman, large trachea, etc. In this case, small woman, we were able to use larger tubes in the majority of patients. Same thing here, and here. For men, most men take 39-41 tubes. Just because someone's small doesn't mean they have a small trachea, and just because somebody's tall doesn't mean they have a big trachea. I've seen 6'3" men that had tiny tracheas, and I've seen little old women who smoked their whole life and had bad emphysema and their airways were like this. And so this formula works when we use. How deep should you advance the double-lumen tube? Now, even if you go to modern anesthetic textbooks, they're going to say insert the double-lumen tube until resistance is met to further obstruction. This I quoted a few of the older things here. The reason for that, goes back to the old days. When they had the red rubber tubes, they were so big that even if you advanced them till you met resistance, it wasn't necessarily deep enough. They're really big. With the introduction of the plastic tubes, these are much, much thinner. And so if you've chosen a thin, small tube and somebody has a big airway, and you advance until you meet resistance, right from the start, you're going to be way too deep. And you're going to have problems. Even when you get out the bronchoscope, it's going to be difficult identifying the carina from the left bronchial carina. You want to advance the tube based on the following criteria. Actually, we were the first here at Stanford to describe malposition of a left-sided double-lumen. It had never occurred before 1985. Now, the reason for that is it wasn't until the early 80s that they introduced the plastic tubes. So in the whole medical literature, nobody had ever described placing a red rubber tube too deeply. Of course, it was impossible. First of all, they're short, and second of all, they're thick. So with the introduction of these plastic tubes, we started noticing sometimes if the tube was advanced too far, you can obstruct the left upper lobe bronchus. Unfortunately, that still goes on today, and I've taken this one from the literature. I didn't cite the article, but here they selected too small a tube. It was a young girl. It was a 16-year-old girl, so they must have a thin tube. It's too small for the airway. They advanced it. They claimed they used a bronchoscope. They said it was in good position. What really happened is they collapsed the right side. They ventilated the left side. The left side was obstructed. They had a pneumothorax, pneumomediastinum, and pneumoperitoneum. So it's important to select the appropriate size tube and advance it based on height. So this is from the original study we did in '91, again showed the bell-shaped curve. But if you look at 1,200 patients, it all concentrates around this. And we used to say 29, the average height of 170 is 29. Somebody in Japan actually reconfirmed the studies that we did here at Stanford, and they actually put a formula to it, which is absolutely correct. The depth of placement for both men and women is to take the height, 1/10 the height in centimeters, and add 12. So if the person who's 170 centimeters, man or woman, is 17 plus 12, there's the 29 I was talking about. So I want to give him credit for taking that data and actually making a very simple formula that I use. 12 plus 1/10 the height in centimeters is depth of placement for both men and women. Doesn't mean you'll be always right. You'll be right probably 90% of the time, and then you're going to fine-tune the positioning. Never overinflate the cuff. Again, this is in vitro. In vitro, this is in vivo. These are low-pressure cuffs. That's one of the advantages of the plastic tubes. But if you overinflate them, they become high-pressure cuffs, and they injure the airway. If you've chosen the correct size tube, you should never need more than 3 cc's of air. So if you looked at the CT scan or the chest X-ray, you selected the correct size tube, you should be able to seal that airway with 3 cc's or less of air. The only exception is the largest tube we have is 41, and there's some people who have gigantic airways, so they may need more air. But if you've selected the correct size tube, 3 cc's of air are needed. All right, very quickly, the way I do it is we place the tube, we inflate both lumens. One of the advantages of the plastic tubes is they're clear, so you can see water vapor. So you should see the chest move, you should hear breath sounds, but you should also see water vapor in both lumens. If you don't see water vapor in one of the lumens, it means that lumen is not open to the lung. And you'll always see the water vapor on the bronchial side, because whether you're right, left, or in bad position, this is the one that's always open to the lungs. As you'll see, this can be obstructed. Then what I do, step B, is clamp. It's a left-sided tube, so you clamp the right side, and you should hear breath sounds on the left. In about 20% of the cases, the tube will go down the wrong side. So you clamp the right side and you hear no breath sounds on the left, you hear breath sounds on the right. It's a left-sided tube. What you do then is deflate both cuffs, pull the tube back a couple of inches till the tip is above the carina. So you just pull it back 2 or 3 inches after you've deflated the cuffs. You bend the patient's head so the ear is to the right and the chin is facing the left. You retwist the tube and you re-advance it. I'll demonstrate it later on a volunteer. That's how the rigid bronchoscopists, that's what they do to get a rigid bronchoscope down the left side. Remember, it's easier to cannulate the right side. It's a direct shot. So you deflate the cuff, pull it back, bend the patient's head to the ear to the right, chin to the left, retwist the tube and advance it. And that works in the vast majority of cases. And then finally, the most important step is with both cuffs inflated to clamp the left and hear breath sounds on the right. The reason it's most important is the tube you can hear breath sound on the left, it may not be deep enough or too deep. This tells you it's in the correct spot. Because if it's in the correct spot, when you ventilate here, this shouldn't be obstructed. What I do is, then we play a game. We look to see if delivering the same tidal volume, if the waveforms are the same. If the tube is in the right spot and the patient doesn't have pleural effusion, this has a tumor or whatever, the lungs are equal, then if you clamp the one side and then clamp the other side with the same tidal volume, you should have the same waveform and peak pressures. So if you do that, you know that both lumens are ventilating equal amounts of lung. It's important to confirm the position with the patient supine and lateral. The only benefit of doing it when the patient's supine is you're down the correct side. Then you turn the patient. What happens when you do that, in the vast majority of cases, the tube pulls back a little. So it's basically a waste of time to take out a bronchoscope if you're satisfied that the tube is in correct position when the patient's supine. It's better to confirm the positioning after you've turned them. So this is what's considered ideal. You take the bronchoscope out, and the cuff is immediately below the groin on the appropriate side. You're not obstructing. Most people don't go down the lumen, but you're supposed to do that to make sure the left upper lobe is not obstructed. And you see this little rim of blue right here. This is what you're seeing. And of course, you turn the patient, the tube never gets pushed in when you turn the patient. When you turn the patient lateral, the tube always, if it's going to move, comes out a little. And so you take the bronchoscope and you see a lot more blue, or sometimes you just see blue obstructing the whole right side. Well, what I do is actually prefer to have the tube a little deeper. And it's called a satisfactory position. You're still not obstructing the bronchus, but you may not even see the blue here. And the reason for that is if it pulls back, it's going to be still in good position after you turn it. But what I do is always feel the pilot balloon when the patient's supine. You inflate that pilot balloon to the bronchus. It's tense. You feel the tube's in good position. You turn the patient. The first thing you do is feel that cuff, that balloon. If it's no longer tense, it means the tube has had to pull back into an airway that's larger. It's no longer sealing the bronchus. More of it is now in the trachea. So even before you get out a bronchoscope, or the tube is going to feel, when it's like this, it's going to have a deflated cuff. Airway trauma is a real thing, knock wood. I don't think we've seen one at Stanford in 30 years, but it's usually due to over-distension of the bronchial cuff. It could be due to forceful insertion. It could be due to movement, but it's almost always due to over-distension of the bronchial cuff from using too large a volume or from using nitrous oxide. So for some reason, if you use nitrous oxide during a thoracotomy, always bleed off some of the volume from the bronchial cuff during the case, because it does expand. This is what it looks like. Almost always it's the posterior membranous portion that's most at risk. That's where the laceration or trauma occurs, not in the protected tracheal anterior portion, but in the posterior portion. So very quickly, DLT placement, select a left-sided tube, measure the airway, select a large tube, remove the bronchial stylet, although this has never been shown to be a risk factor. Advance the tube down the bronchus based on height. Inflate. Some people use a 3 milliliter syringe just to remind themselves not to overinflate it. If more than 3 milliliters are needed, reassess position. Conserve when the patient's supine and lateral. Bleed it off if you use nitrous, and deflate the bronchial cuff when it's not in use. So we've successfully placed our double-lumen tube. Now, how do we manage one lung ventilation in 10 minutes? Normally, when you turn a patient in the lateral position because of gravity, 40% of the blood flow goes to the up lung, 60% to the down lung. And then you collapse that lung. Even under the best of circumstances, you're going to have a shunt wasted perfusion of at least 20% to the up or operative lung. The key is to try to minimize this. So one lung ventilation, for reasons I'll show in a moment, I think you should always use an FiO2 of 100%. I use, and we can talk about this, there's a lot of things now on valutrauma and barotrauma, but I think the safest is to use 10 milliliters per kilogram based on patient's ideal body weight to the dependent or ventilated lung, and to ventilate the patient at a rate that keeps the patient normal carbic. So here's a study where they use 30%, 50%, and 100%. You can see the arterial oxygen tensions with 30%. Well, I suppose you can get by, and with 50% it's adequate. But if you want to safely ventilate the patient, you want to use 100%. Now, if the VQ matching was perfect, you and I were breathing 21% oxygen now, and we're not hypoxic. But that's not the case, as we'll see during one lung ventilation. So I think it's safest to use the large, high FiO2 to have the highest PO2s achievable. Again, this is with these various concentrations. They had desaturation events. It's extremely rare in our practice to have patients who are hypoxic during one lung ventilation, so I don't know how you can have 26 or even 2 hypoxic events during a case. We did a study here with 1,200 patients, and we only had 33 patients out of 1,200 that had SATs below 92. This is the effect of larger tidal volumes. This is 7 milliliters per kilogram. This is 14, which everybody would agree is way too high nowadays. But you can see oxygenation improves with higher tidal volumes. The rate is important also. If you ventilate the patient too fast, especially if they have emphysema, you're going to have that stacking. You're going to have inspiration going in, but not all of it coming out. And so your intrinsic PEEP or auto PEEP and CO2 increase in the patients if you ventilate them too fast. And of course, if you're using small tidal volumes, one of the, we don't have to get into it, but one of the controversies now in anesthesia is protective ventilation. And one of the things people are recommending is using sometimes really, really small tidal volumes. The only way to maintain that minute ventilation then is to use rapid rates, and then you get into these problems. And if you don't use rapid rates, then the CO2 goes sky high, and you have what's considered permissive hypercapnia and bad respiratory acidosis in some very sick patients. So what are the causes of hypoxia during one lung ventilation? I always ask the residents, and I've listed them here, but this is the one that's always given first. Oh, well, let's start with double-lumen tube malposition. It could only be a problem 50% of the time. It can only be a problem if you're using a left-sided tube during a right-sided operation. If you're using a left-sided tube during a left-sided operation, you're collapsing the left lung and ventilating the right side. So even if the tube is malpositioned, it's not going to interfere with the surgery. But if you're using a left-sided tube like I could recommend, and the surgery is on the right side, if the tube is malpositioned, you're going to collapse the left upper lobe. Because we're never going to happen to us because we'd only be ventilating one lobe and we'd see peak pressures are way too high. So this would have been picked up earlier or been picked up with the bronchoscope. So a malpositioned double-lumen tube is only a potential problem with a left-sided tube during a right operation. If the tube is malpositioned and not deep enough, it's just the opposite. You would no longer be sealing the airway. So rather than having hypoxia, you'd have the surgeon complaining that the lung is being ventilated. So it's only a too deep a tube. So the problem is shunt. As long as you have adequate ventilation and adequate perfusion down here, you'll be able to maintain oxygenation. Regional hypoxopulmonary constriction is that you've collapsed this lung. The lung vessels are the only ones, the pulmonary vessels are the only ones who vasoconstrict during hypoxemia. Everywhere else, vessels vasodilate to deliver more oxygen to ischemic tissue. But the pulmonary tissue, the vessels vasoconstrict to redirect oxygenated blood to areas that are being ventilated. And if you take an experimental animal, and this is with hypoxic vasoconstriction, this is without hypoxic vasoconstriction, you collapse 50% of the lung as you would during a thoracotomy, And you can see the PO2 is very, very low without hypoxic vasoconstriction, and it's much higher with it. So I always ask, what are the effects of the anesthetics on hypoxic vasoconstriction, right? All the inhalation agents usually depress it. I put plus minus, and I'll show you why in a minute. All the intravenous drugs maintain hypoxic vasoconstriction. So whether you're using ketamine, etomidate, pentothal, propofol, if you did a straight tier anesthetic, you would maintain hypoxic vasoconstriction. If you use an inhalation agent, this is what happens. The direct effect is it inhibits hypoxic vasoconstriction, increases shunt. But all the inhalation agents have indirect effects. If they depress cardiac output and increase oxygen consumption, they lower mixed venous O2, which stimulates hypoxic vasoconstriction, which decreases shunt. But the question is, since the intravenous anesthetics all maintain it, why aren't we using intravenous anesthetics solely for our thoracotomies? Well, here's the reason. Here's a study with isoflurane versus propofol. Absolutely no difference in oxygenation during one-lung ventilation. Here's a study of propofol versus sevoflurane. Absolutely no difference in oxygenation during one-lung ventilation. The reason for that is all those studies on hypoxic pulmonary vasoconstriction are in experimental conditions. They're in the intact sheep model, and everything is intact except for the hypoxic vasoconstriction. In real life, the surgeon has retractors in his hands in the chest, and he's injuring the lung, and he's causing lots of release of vasoactive substances that cause vasodilation. They obliterate hypoxic vasoconstriction, and they decrease PO2. So the anesthetic you use is really not important because there's not going to be hypoxic vasoconstriction. What is the real important factor? Well, this is position. I think gravity is the most important factor. These are patients who all have the same anesthetic, so hypoxic vasoconstriction is the same. This is in the full left lateral decubitus position. These are the PO2s in the semi-lateral decubitus position. This is supine. So in every single case, if the patient's fully in the lateral decubitus position, gravity means blood flow to the dependent lung is greatest. When they're sort of in a semi-position, there's less gravity. And when they're supine, there's no effect of gravity, and the PO2 is the lowest. So gravity is more important. When you collapse the lung, it takes about 10-15 minutes for the oxygenation to all be extracted. The shunt continues. So what are the strategies if you have a patient who's hypoxic during one lung? You can oxygenate the shunted blood, right? That blood is going through non-ventilated area. There's several ways to do it. One is, this doesn't work. Continuous oxygen insufflation doesn't work. If you put a catheter in there and you attach it to oxygen, it's not going to get the alveoli or collapse. You've collapsed that lung, so you're not going to get to areas of gas exchange. You can give a single breath intermittently. That works fine. You just give a single breath to the operative lung, collapse it. It's no longer moving. But any blood that's going through it's going to pick up the oxygen. You just have to do that frequently. Or you can add CPAP. So what CPAP does during one-lung ventilation, it maintains the patency of the non-ventilated alveoli with oxygen, and that oxygenates the blood. But it also distends the alveoli, and that increases pulmonary vascular resistance. And so that redirects blood flow to the good lung. You've increased the resistance on the bad side. So this is what it does. You're oxygenating here, but you're also forcing more blood down. So it has two effects. We won't go how the CPAP works. 2-lung ventilation, 1-lung ventilation, CPAP, it always improves it. The problem is that you have to be able to inflate that operative lung for it to come down to whatever pressure you've set it at. And so you can't use CPAP if a surgeon has a clamp on the bronchus, if it's obstructed, if the airway is not intact, if there's blood or empyema in the airway. You have to be able to inflate the operative lung and allow it to collapse down to whatever CPAP you've set it at. And so you can't use it all the time. And you can't use it during thoracoscopy because any distension of the lung during thoracoscopy is going to obstruct the surgeon's view. The main causes of problems during thoracotomy is either under ventilation of the good lung or under perfusion of the good lung. So in order to prevent hypoxia or treat it, not only do you want to use a high FiO2, but you have to use an adequate tidal volume. You've collapsed the operative lung. If you're using too small a tidal volume on the dependent lung, you're going to get further atelectasis. All the abdominal contents push up on the diaphragm. You're using small tidal volumes. The weight of the surgeon and everything is pushing down. So this trend to use smaller tidal volumes leads to more atelectasis and more hypoxia. And again, this is shown here. The concern is this is a higher tidal volume, 8 per verse 16. This is rate. Here's a high tidal volume versus low volume in one-lung ventilation, and these are pretty high tidal volumes. Anyway, they looked at the markers for lung injury, because that's why you theoretically don't want to use large tidal volumes, and they found no differences. Here it is here. So the ventilatory setting did not affect the inflammatory markers whether you use larger, small tidal volume. So this is one of the fads that's going on in anesthesia right now, without any proof or evidence that small tidal volumes does any good, and with lots of evidence that it can be potentially harmful by causing hypoxia and hypercarbia and auto-PEEP. There's a push by some people to use that. So this, read responsibly. You could add PEEP to the bottom lung, but if you add PEEP here and you increase pulmonary vascular resistance, you're going to increase shunt. So I've never done that. And some people even do CPAP and PEEP. The real thing for the future, and what I'm going to end with, is the pharmacologic modulation of the pulmonary blood flow. And what it is if you can decrease blood flow to the operative lung, the pulmonary artery, if you decrease blood flow, more blood has to go to the non-operative lung, and you improve oxygenation. Or if you can selectively increase flow to the ventilated lung, then you're going to improve it. So how do we improve? How do we provide selective vasodilation? What's the magic molecule? Nitric oxide. The non-selective, nitroglycerin and nitroprusside both work indirectly. They cause nitric oxide to be produced, but it's non-selective. So if you use nitroglycerin and nitroprusside during one-lung ventilation, all the pulmonary vessels are vasodilated. That worsens hypoxia. In theory, if you use inhaled nitric oxide, which is a selective vasodilator, in theory you should increase perfusion to the ventilated lung and improve oxygenation. The problem is it doesn't work. With nitric oxide, without nitric oxide, it's the same. And the reason for that is in normal lungs, with normal pulmonary artery pressure, there's no increase in blood flow to the good lung. If you have a patient who has elevated pulmonary artery pressures, elevated pulmonary vascular resistance, and a hypoxia, and then you add nitric oxide, you do decrease flow there, and you do improve it. So the way to get around, and the way people have done that, is to vasoconstrict the pulmonary artery to the good lung, to the bad lung, and vasodilate the pulmonary artery to the good lung. And you can do that with a number of things, but the one that's used in Europe is a drug called almatrine. It's a selective pulmonary vasoconstrictor. So by selectively vasoconstricting blood flow to the operative lung while using nitric oxide to selectively vasodilate blood flow to the good lung, during one-lung ventilation, they can get arterial oxygen tensions that are the same as when you ventilate the patient with two lungs.
Is that an inhaled drug?
Yeah, but it's not available here. So what they do here in the United States is use phenylephrine. They use it more in the ICU than in the ORs. In theory, you could give phenylephrine, in theory, vasoconstrict both pulmonary arteries, and then give nitric oxide to vasodilate the good one. But I've never seen it needed, and as I said, it's extremely rare to get hypoxia during too-long ventilation. If you do, the things I've told you here. Anyway, that's a quick, hopefully practical guide to anesthesia for thoracic surgery, and it's about 45 minutes, so take any questions.
Manipulation of the two just allow positions, you often have to get to sleeping and afterwards, or you can take it.
Well, yeah, I always tape it initially, but I tape it, I don't use your techniques where you tape with the red tape and just all the way up. I try to use what they do in pediatrics and tape it right at the skin. The problem is not just the taping. It's not just the positioning. Every time we try it with an endotracheal tube, if you bend the head back, it pushes the tube deeper. It's taped in one spot, and if you do it this way, if you bend the head this way, it pulls it out. So the actual physical movement and the moving of the head, when we stabilize it, that usually pulls the tube back. I've never seen it pushed in. I don't know. I mean, it seems to me if you tape it beforehand, more chance of it being dislodged during the movement. But it's interesting. Be an interesting study, actually.